In this second video for Unit 4, we're going to be talking about adverse transfusion reactions that can occur and then the lab's role in those transfusion reactions. Okay, so an adverse transfusion reaction is defined as an undesirable response by a patient temporarily associated with the administration of blood or blood products. So some of those clinical signs of a transfusion reaction could be the patient develops a fever with greater than or equal to a 1 degree Celsius increase or greater than 38 degrees Celsius, chills or rigors, respiratory distress, so that can be defined as wheezing, coughing, dyspnea, or cyanosis, which means they're turning skin starts to turn blue, hyper or hypotension, pain, either abdominal, in the chest, flank, back, or at the infusion site. Some skin manifestations such as hives, rash, flushing, or edema, jaundice or hemoglobinuria, nausea or vomiting, abnormal bleeding, oliguria or anuria, so either a decrease or a cessation of urine flow, shock, and DIC. And if you remember, we talked about DIC, which stands for disseminated intravascular coagulation. We talked about it some last semester, and that's when it usually comes from some type of traumatic event where your body has got so many bleeds that it's trying to plug with those coagulation factors that it eventually the coag factors run out. And keep in mind that the entire time a patient is receiving a blood transfusion, they're being monitored at certain intervals by the nurse, and vitals are being recorded. So the nurses are on the lookout for any of these types of symptoms, and they're going to record that any of those changes in symptoms, and it's up to the doctor then to determine, the nurse might notify the doctor and say, hey, I think we're dealing with a transfusion reaction here, and the doctor is going to be the one to make the call to say that it's a transfusion reaction and to stop the blood transfusion. Most transfusion reactions are due to clerical and human errors relative to the patient, the sample, and the blood unit ID. So that's why it's so important in blood bank when we issue a unit of blood to go through that information that's on the tag that we have attached to that unit that was cross-matched for that patient. We go through all of that information with the nurse, and it's meant as kind of a double check. So we just want to make sure that we do our part correctly on the transfusion. Most important factors determine the outcome of incompatible transfusion. So the potency of the recipient's anti-A or anti-B in their plasma. So if that patient has naturally occurring anti-A or anti-B in their plasma, how strong is that antibody? How strong of a reaction can it have with its intended antigen? The volume of the incompatible blood transfused, so how much of that blood was able to be transfused into the patient, and then the rate of transfusion. So especially in the case of emergency release, or if you have a patient who is actively bleeding, they're going to try to transfuse or infuse that blood at a faster rate. So how much were they able to get transfused into the patient, and how fast were they transfusing? Okay, so this may occur as an acute, meaning less than 24 hours, or as a delayed, meaning greater than 24 hours reaction after the transfusion, and then it gets further categorized as either immune-mediated or non-immune mediated. So the transfusion reaction is going to get categorized as either acute or delayed, and then immune or non-immune mediated. So with immune-mediated, We've got reactions that are involving those antigen-antibody complexes. You've got cytokine release or complement activation. And remember, cytokines are those chemical messengers, so they're constantly monitoring our body, our immune system, and if they see that something is out of line, then they're going to let everybody else know. And then immune non-mediated, these are reactions that may result from the component that's transfused, so something with the unit itself, or something to do with the patient's underlying condition, or something to do with how the unit was infused. Okay, so some different categories of transfusion reactions. So hemolytic transfusion reactions. This is when we have destruction of the red cells that results in intravascular or extravascular hemolysis, or both. So it's classified as acute or delayed, and this may come from immune or non-immune causes. So immune-mediated acute hemolytic transfusion reactions, and we're going to go through several of these different categories or names here. Let me back up here for just a second because I think my notes go on a little bit beyond this. So with intravascular hemolysis, you've got red cell hemolysis, so those red cells are being destroyed, that occurs within the blood vessels. Usually this is going to be due to IgM activation of complement, and IgM is more efficient at activating complement due to its bigger size. So if you remember back to Unit 1 when we were talking about all the different classes of immunoglobulins, IgM is a pentamer. So it's bigger, it has a longer reach, so it's more efficient, it's better at activating complement. And then extravascular hemolysis, so in transfusion medicine, the antibodies attached to red cell antigens can signal clearance in the liver and spleen. That process is called extravascular hemolysis. So this happens more with your IgG antibodies, since they're not as effective at activating complement because they're smaller. Instead, phagocytes and macrophages in the liver and spleen recognize that IgG and they're going to take them out. Okay, so now moving on to the immune-mediated acute hemolytic transfusion reactions. So in this category, you've got rapid destruction of the red cells. So it either occurs immediately after or within that 24-hour window of the transfusion. The clinical presentation can range in severity from fever to death. Some of the more common symptoms can include fever, chills, pain, oozing at the infusion site, back or flank pain, hypotension, epistaxis, which is just a nosebleed, hemoglobinuria, DIC, oliguria, anuria, and can lead to renal failure. So this type of transfusion reaction is usually going to be due to an ABO incompatibility. So you've got interaction of preformed antibodies in the recipient, so those are those naturally occurring antibodies, to red cell antigens on the transfused cells. This activates complement. This is the most severe of the hemolytic reactions, and the severity of that reaction again can be influenced by how much circulating antibody is in the recipient's blood and the density and distribution of red cell antigens on the transfused cells. So essentially it comes down to how much antibody is in the patient's blood, how many antigens are on the donor red cells. Okay, IgM antibodies rarely activate the classical pathway of complement at 37 degrees or body temperature. Leads to intravascular hemolysis, which releases free hemoglobin and red cell stroma. The stroma is the membrane of the red cell that has been lysed. So it releases that into the plasma. IgG antibodies rarely activate complement, but they can interact with the Fc portion of mononuclear phagocytes, so that can affect phagocytosis and cellular activation. Okay, and then the role of complement in this process, there are three stages. Opsonization is the first stage. So you've got your membrane-bound complement products that are cleared by mononuclear phagocytic cells. You've got anaphylatoxin generation. So they're potent inducers of inflammation that release into the plasma. They act on the mast cells, smooth muscles, and the neutrophils. So then at that point, you've got that kind of cascade that we talked about in, I think that was Unit 1. So I won't go back through each one of these individually again. The role of complement. So this just continues on this page. And then hemolysis, which is the outcome of complement activation after the assembly of the membrane attack complex. So at this stage, you've got liberated hemoglobin is bound by plasma haptoglobin. So when the hemoglobin binding capacity of plasma haptoglobin exhausts, hemoglobinemia, which is when you have free hemoglobin in the plasma, and hemoglobinuria are detectable in plasma. Free hemoglobin released into the bloodstream has cytotoxic and inflammatory effects. So when this happens, the patient's going to be feeling the results of that. Okay, hemostatic dysfunction. Antigen-antibody complement complexes may initiate the coagulation in fibrinolytic systems. So this is where you often have DIC associated with acute hemolytic transfusion reactions. And if you remember from last semester when we talked about DIC, some of those cardinal signs of DIC are the consumption of all of those clotting factors, so especially fibrinogen factor 5 and factor 8, and the platelets. You've got diffuse, uncontrolled microvascular bleeding. So it's like all of these little tiny bleeds all over the patient's body. DIC causes bleeding into the organs and multiple organ dysfunction or failure because of those bleeds. Microvascular thrombi promotes tissue ischemia and release of tissue factor, which encourages activation of more thrombin. So patients will clinically present with low platelet counts, decreased fibrinogen, and decreased fibrinogen degradation products, so especially your D-dimer. Okay, and then shock and renal failure. So shock is an abnormal condition of inadequate blood flow to the body's peripheral tissues with life-threatening cellular dysfunction. So this is caused by the release of the anaphylatoxins, vasoactive amines, kinins, and cytokines into circulation. So all of those chemical messengers that kind of work in a system together, once something is recognized as in the body that's going on that shouldn't be happening, all these chemical messengers start releasing their products. This can result in renal failure due to systemic hypotension, reactive renal vasoconstriction, deposition of intravascular thrombi, which compromises the renal cortical blood supplies, and then release of norepinephrine in reaction to that hypotension. And shock produces vasoconstriction in the kidneys and lungs, which then leads to renal ischemia, which may be transient, or it can advance to acute tubular necrosis and renal loss. And ischemia is loss of blood flow. Okay, then we've got immune-mediated delayed hemolytic reactions. With this type of hemolytic transfusion reaction, you're going to have symptoms that appear greater than 24 hours after the transfusion. And these types of transfusion reactions are caused by some type of secondary immune response. So the recipient experienced immunization after exposure to the red cells from either prior transfusion or pregnancy. And sometimes that might not be detected in pre-transfusion testing due to low levels or sensitivity of the test method. Some of the first signs of delayed hemolytic transfusion reaction are inadequate increase in hemoglobin levels. So remember, I think it was in the previous video, we talked about how the patient who receives a transfusion is going to have a CBC or a hemoglobin level performed before the transfusion and then after the transfusion, and those hemoglobin and hematocrit levels are supposed to increase by a certain amount. So if you're not seeing that increase in the hemoglobin levels that you should be seeing, that could be an indication of a transfusion reaction. Unexplained appearance of spherocytes, newly identified alloantibodies, and then some other symptoms could include jaundice, which could be on day 5 or after the transfusion, as well as hemoglobinuria. Some of the blood groups that are associated more so with delayed hemolytic transfusion reactions are the Rh blood group, especially big C and big E, KID, Duffy, KALE, and MNS. And this goes back to a previous lecture where we talked about when you're trying to identify an antibody that a patient has, how this information can come in handy. So just like when you're trying to identify an antibody, if you're trying to identify the cause of a delayed hemolytic transfusion reaction, this information could be helpful. And then sensitized red cells are removed from circulation by macrophages in the spleen and by the Kupffer cells in the liver. Mononuclear phagocytes generate cytokines that mediate systemic effects associated with this type of transfusion reaction. Okay, and this was a good chart. I think this chart's in the book, but I'm going to let you guys look over this because it's essentially the information that I just got finished talking about, but just some differences in acute versus delayed hemolytic transfusion reactions. So it's going to compare the patient's clinical signs and symptoms, complications that can occur, what causes those different types of transfusion reactions, the laboratory tests that we could perform that could help with that determination, how you treat, and then how you prevent. So just take a look at that chart. Okay, non-immune mediated mechanisms of red cell destruction. So once an alloantibody has been ruled out as the cause of a transfusion reaction, you're going to begin investigation into possibilities of a non-immune related response. So examples of causes for non-immune mediated red cell hemolysis could be exposure of the red cell unit to extreme temperatures. Could be due to maybe a malfunctioning blood warming device or units that are stored without cryoprotectants. Improper deglycerylation of the red cell units on thawing, and we get a little bit more into that in the last lecture in this unit when we talk about blood products and the components. So this is why we want to observe the supernatant of the donor unit, especially if it's been deglycerolized. Mechanical destruction of the red cells, so small bore needles, mechanical valves, excessive pressure in blood salvage equipment can cause hemolysis of the cells. Incompatible solutions, so the blood is mixed. If the blood is mixed with any solution other than physiologic saline, it can cause osmotic rupture of the red cells. Transfusion of bacterially contaminated blood products. So this is one of the reasons why we visually check the product before we issue it. But bacterially contaminated blood products are usually going to be associated with a febrile reaction in the patient. And then some type of intrinsic red cell defect attributable to a clinical condition in the donor, so such as sickle cell disease, thermal burns, G6PD deficiency, or PNH. So any of these, the last two slides, any of those are going to be things that that cause the transfusion reaction, but it's not due to something that's going on with the patient. It's more something that's going on with the the unit. Okay, delayed serologic transfusion reactions. So in this type of reaction, you're going to have an anamnestic response after the transfusion with no signs of hemolysis. So this should be considered if an antibody develops between 24 hours and 28 days after the transfusion, even though there is adequate maintained hemoglobin response. So you could do a new ID, antibody ID panel to confirm it, or a positive DAT could confirm that. Febrile non-hemolytic transfusion reactions. So the symptoms that the patient presents with in this type of reaction are going to be similar to those in an acute hemolytic transfusion reaction. So you have to investigate to rule out hemolysis. It's usually going to come with a 1 degree Celsius or more rise in temperature occurring during or shortly after the transfusion, so up to 4 hours after the transfusion. Some other symptoms of this type of reaction could be chills, rigors, headache, vomiting. This one is not necessarily a major threat to the patient, so it's not necessarily going to be as severe and have as severe of consequences as some of the other types, but it can just be very uncomfortable for the patient. But this one can usually be managed with acetaminophen, which is Tylenol. The most common cause of this type of transfusion reaction is due to transfused cytokines or the action of cytokines generated by the recipient in response to transfused white cells. Antibodies to donor HLA antigens have also been implicated. HLA stands for human leukocyte antigen, and we're going to talk about that more in the last unit. So the use of leukocyte-reduced platelets and red cells has decreased the frequency of febrile reactions. So if we want to try to prevent febrile reactions, leukocyte-reduced platelets and red cells can do that. And that's considered kind of the norm now. Allergic transfusion reactions. So the cause for this one is going to come from soluble allergens that are present in donor plasma. So reactions with this one can range from minor symptoms such as hives to more severe, such as an anaphylactic shock, and it can lead to death. Symptoms can occur within seconds or minutes after the start of the transfusion. So some of those mild reactions, and these are also called urticarial reactions, result from the exposure to the foreign allergen in the blood product that's being transfused. So this is a type 1 hypersensitivity reaction, where you've got IgE antibodies in the recipient that react with some type of allergen, which is going to be a plasma protein in the donor unit. This activates mast cells. This leads to degranulation and release of histamine, proteases, and chemotactic factors. So the main symptoms with this type of reaction are going to be hives and itching. A more severe reaction, which is referred to as anaphylactic, this is due to a non-IgE mechanism. It triggers the mast cell degranulation. Most cases are going to exhibit urticaria, which is wheals or hives, and angioedema, which is swelling, but it can also lead to severe hypotension, shock, loss of consciousness with respiratory involvement, possibly also GI symptoms. Okay, 2 or more of the following symptoms within 4 hours of the transfusion are considered definitive for categorizing the transfusion reaction as an allergic type. Hives, itching, maculopapular rash, which is flat and raised skin lesions, generalized flushing, localized angioedema, edema of the lips, tongue, or uvula, which is the little flappy thing in the back of your throat, erythema and edema of the periorbital area, so that's around your eyes, conjunctival edema, that's the inner lining of the eye, respiratory distress, bronchospasms, and hypotension. So any of those, 2 or more within 4 hours, are considered allergic reactions. And then mild reactions usually can be treated with antihistamines like Benadryl. So severe reactions may require treatment with prednisone or epinephrine. Okay, transfusion-related acute lung injury, which is also referred to as TRALI. So this can be a life-threatening or fatal transfusion reaction. You've got a lot of overlapping symptoms with transfusion-related sepsis, circulatory overload, and anaphylactic reactions. So some of the symptoms that the patient may present with in TRALI are respiratory distress and pulmonary edema during transfusion or within 6 hours after the transfusion, 1 to 2 degree Celsius increase in temperature, chills, severe hypoxemia, which is oxygen deficiency, dyspnea, so the patient has labored breathing. I just realized all the symptoms are not included on this slide, so I'll go back and add those. Non-productive cough, tachycardia, increased heart rate, and hypotension. Okay, so I went back and added those additional symptoms of TRALI. The exact mechanism of lung injury in TRALI is not completely understood, but the current belief system states that TRALI occurs from the result of 2 events. So the recipient's underlying medical condition in conjunction with the transfusion. So something about those 2 factors together leads to this TRALI type transfusion reaction. So some risk factors that could be implicated: plasma from female multiparous donors repeatedly exposed to fetal HLA antigens may generate a wide variety of HLA antibodies and neutrophil antibodies. So presence of anti-HLA class II antibodies are strong predictors of TRALI risk. Multiparous means patient or female who has been had multiple pregnancies. And then AABB, TRALI risk mitigation standards. So AABB is the kind of the Bible of blood bank. I can't remember what the American Academy of Blood Banks maybe is what that stands for, but they put out a book, I think annually, that just kind of has like all the standards related to blood bank. So they're an organization that strictly works with blood bank standards. So their risk mitigation standard for TRALI says that plasma and whole blood for allogenic transfusion will be from males, female who have not been pregnant, or females who have been tested since their most recent pregnancy and results interpreted as negative for HLA antibodies. Okay, next is transfusion-associated graft versus host disease. This one has a 90% mortality rate, but it's a very rare complication of transfusion. This one is mediated by immunocompetent donor lymphocytes in cellular blood components. So symptoms are going to occur anywhere from 3 to 30 days after the transfusion, and the patient would present with rash, fever, nausea, diarrhea, pancytopenia, elevated liver function tests. So after the transfusion of donor lymphocytes to an immunocompromised patient, the donor lymphocytes engraft and mount an immune response against the host tissues. So the host is unable to destroy the transfused cells. So because of that, donor lymphocytes are going to proliferate and respond to unshared histocompatibility antigens in the host. This is most often seen in immunocompromised patients. So because of that, any immunocompromised patient should receive blood products that have been irradiated. So irradiation eliminates the ability of leukocytes to replicate and mount that immune response. It also inhibits T cell response of the donor. So leukocyte reduced for these types of patients is not enough. And anytime, if you're working in like an oncology clinic or working with cancer patients, you're almost always going to use irradiated blood for those patients. Okay, bacterial contamination of blood. So bacterial proliferation can occur in donor units during storage, and transfusions of even very small amounts of contaminated blood can be fatal or cause serious illness or morbidity. Some major sources of bacterial contamination can include the donor has asymptomatic bacteremia at the time of donation, rare bacterial infection that can survive in storage conditions recommended for red cells and platelet components, or some type of system failure. So maybe there's a pinhole in the blood collection set, there's some type of testing area, or somebody is not following standard operating procedures, so it allows for bacteria to be introduced and to proliferate. Some of the clinical symptoms of this type of transfusion reaction can mimic acute hemolytic transfusion reaction, so the patient can have fever, chills, headache, hypotension, shock, muscular pain, vomiting, diarrhea. The number of infused organisms influences symptomatic presentation and clinical outcome. So how many of those organisms were in the unit, how many of them actually got transfused to the patient. So treatment has to be immediate in order to prevent fatal outcome. The recipient will receive a broad spectrum antibiotic. Blood cultures are obtained from the patient and from the blood bag, and the donor unit should have been inspected at the time of issue, but maybe, it was something that was not really evident to the naked eye. Most contaminating organisms would die in a donor unit after several days in storage at 4 degrees Celsius, but some organisms are capable of growth at this temperature and can even thrive in these conditions. So I don't know how much you remember about these organisms from last semester, but Yersinia, Enterocolytica, Serratia liquefactions, Pseudomonas fluorescens, and Listeria monocytogenes. All of those can survive in colder temperatures. Platelets are stored at 20 to 24 degrees Celsius, which is room temperature. So that would be a lot more organisms can survive in at room temperature versus refrigerated. So that can include staph and strep species, E. coli, Bacillus cereus, Klebsiella, Serratia, and Enterobacter. Okay, next is transfusion-associated circulatory overload, also referred to as TACO. This one is defined by the CDC as infusion volume that cannot be effectively processed by the recipient because of high rate and or volume of infusion or underlying cardiac or pulmonary pathology. This one, TACO, now is considered the leading cause of mortality from transfusions. Patients 70 years or older and infants are going to be at the greatest risk, and that's because they don't have those developed immune systems. Patients with compromised cardiac and pulmonary status are not going to tolerate rapid elevations in total blood volume, so they're going to be more susceptible to TACO. So some prevention methods, just avoid transfusion of large volumes of plasma, transfuse red cells versus whole blood, transfuse products at a slower rate. And then dyspnea, severe headaches, and increased BNP can be seen after transfusion in these patients. Transfusion hemosiderosis or iron overload. This can be a potential complication in patients undergoing long-term transfusions. So some patients have conditions, sickle cell is the one that comes to mind, but some conditions require that patients routinely undergo blood transfusions. So hemosiderosis could be a complication of that. So this results from the accumulation of excess iron in macrophages in various tissues, so especially the liver, heart, and kidneys, because iron intake exceeds the daily iron excretion, which is 1 milligram per day. So you're taking in more iron than your body can get rid of. So this happens when non-bleeding patients have received greater than 20 transfusions. Iron deposition can interfere with the liver function, heart, or endocrine glands. So to prevent this, we want to use iron chelators, which allows the body to bind and excrete the excess iron through urine and feces. Oops, I've got the same information on 2 slides. Okay, so the next one is citrate toxicity. So citrate, which is present in anticoagulants used in the blood collection process, binds to ionized calcium. So transfusion of large quantities of citrated blood in a short period of time introduces the risk of citrate toxicity. Also, patients with impaired liver function who can't properly metabolize the citrate. So to prevent this, we just remove the plasma that contains the additive or injections of calcium chloride or calcium gluconate to negate those toxic effects. Okay, post-transfusion purpura. So purpura is a rash of purple spots on the skin caused by internal bleeding from small blood vessels. The patient's platelet count is going to plummet within 2 weeks after the transfusion of blood or blood products containing platelets. So there's going to be an increased probability of bleeding episodes that will follow. This is an anamnestic response to a previous sensitization with the high incidence platelet antigen, HPA-1a, which has a 98% frequency in the population. Antigen negative individuals are going to be at risk for developing PTP. So you've got the HPA-1a negative women that get sensitized through multiple pregnancies. They're going to respond to the immune production of APA-1a. This leads to platelet-specific antibody that destroys the transfused HPA-1a platelets and also the patient's HPA-1a negative platelets. So the treatment for this one is plasmapheresis or exchange transfusions or intravenous immunoglobulin. Okay, evaluating and reporting a transfusion reaction. And this is not going to be up to us to evaluate the patient or to report a transfusion reaction. Again, that's going to be up to the nurse who monitors the patient and to the doctor who declares it as a transfusion reaction. We're just the ones that do the post-transfusion testing. But when we get this in the lab, we refer to it as a transfusion reaction workup. And then there's all these steps that we have to take, and we turn our information over to the pathologist who makes a determination. So again, that patient gets monitored throughout that transfusion, and then for 4 to 6 hours after the transfusion. If an adverse reaction is suspected, the following steps should be taken. So we want to stop the transfusion immediately, re-identify the patient and the transfused component. So that's kind of like a recheck on the clinical or the clerical aspects of the process. Notify a blood bank and the doctor of the suspected reaction. Maintain an IV line with normal saline. If any signs or symptoms of possible acute hemolytic transfusion reaction, anaphylaxis, TRALI, transfusion-induced sepsis, or other serious complications exist, we need to collect a post-reaction blood sample for evaluation. So that the floor is going to send that post-transfusion sample. They're going to send the blood unit, all related forms and labels back to blood bank so that we can do our evaluation and our workup. Okay, so the lab's role in a suspected transfusion reaction. So we're going to start with that clerical check for errors in identification. So the patient's sample and blood components are going to be checked for any errors relating to identification of the patient. There's going to be a visual check on the patient's sample for hemolysis or icterus. So we're going to compare the pre-transfusion and post-transfusion samples for the presence of icterus or hemolysis. Since red cells immediately release free hemoglobin into the plasma during intravascular hemolysis, any pinkish or reddish discoloration would suggest that free hemoglobin is present in the sample. Icterus may be present if the transfusion has occurred over a 3 to 4 hour period. So you've got degradation of free hemoglobin to bilirubin that's going to progress. Bilirubin levels are usually going to peak at 5 to 7 hours after the hemolytic event. We can perform a DAT. So the post-reaction DAT checks for serologic incompatibility. So if the post-reaction sample is positive, a recipient alloantibody may have sensitized the transfused red cells. So this is going to appear as a mixed field reaction. If the transfused cells have been cleared rapidly, the DAT could be negative. Other serologic tests as needed, and then if the patient has a febrile reaction without hemolysis, the blood unit is going to be cultured for bacteria. Okay, and then here's just some a chart with some additional testing that we could perform in the investigation of a transfusion reaction. So look over that list. And usually if we're investigating a transfusion reaction, we're going to redo all of our testing on the pre-sample and the post-sample. So we're going to redo that ABO and RH, so patient's type, we're going to redo that screen, we're going to redo the cross-match on all of those pre- and post-transfusion samples. And then here are some others that we may end up having to do depending on what type of transfusion reaction they suspect. Okay, so that's the end of this lecture on transfusion reactions. The last lecture in Unit 4 is going to be on the actual blood collection process for donors and the blood component preparation and donor requirements.